So let's look a little bit at physiologic tolerance of anemia and a transfusion threshold. So specific to this patient is transfusion in hip replacement. And this was a randomized controlled trial that was published back in 2011 called the FOCUS trial. It was a randomized trial of 2,000 patients with hip fracture who required surgery, so not exactly this patient, but related to this patient. And if you click on this, what are the outcomes? This is the patient population was a mean age of 81. 2/3 of the patients had known cardiovascular disease or risk factors for cardiovascular disease. And if you keep clicking through this, you would find that their primary outcomes were no difference between the liberal and restricted transfusion group. Unfortunately, Jeff Carson used hemoglobin 8 versus 10 as the threshold for transfusion. And for those of you who are part of the AABB, you know that the AABB guidelines still stipulate hemoglobin threshold less than 8 as being the appropriate threshold for patients with hip fracture. I think that that's wrong. I think that there's no reason to, it's just Jeff Carson is very attached to randomized controlled trials as the only source of data for making clinical decisions. And because his trial used 8 instead of 7, he says 8 is the only proven safe threshold for transfusion in this setting. My personal belief and what I advocate for in the hospitals that I'm involved with is that patients with hemoglobin between 7 and 8 who have undergone hip surgery, if they're hemodynamically stable, it's just fine to leave them there, and you ought to manage their anemia in ways other than transfusion, as you'll see with this patient. And a low rate of cardiovascular events in both groups. So let's move on. Let's look at pre-op anemia management in this particular patient. Pre-op anemia management, we know that that's important, that the most frequent predictor of transfusions in the operative patient population is preoperative anemia. It's the one risk factor, modifiable risk factor that we can do something about. We can't do anything about a patient's gender, age, body mass, or comorbidities, but we certainly can and should treat their anemia. NSQIP database study, once again, this was a study published by Muslim and Lancet back in 2011. Even mild anemia, and that was defined as a hemoglobin between 10 and 12 in women, between 10 and 13 in men, was associated with higher 30-day adjusted mortality and increased morbidity. The problem is that treatment of preoperative anemia with a transfusion did not improve the clinical outcomes. We want to manage that anemia by means other than preoperative transfusion. So let's look at this particular patient's iron studies. You can see that his percent saturation at the time that he came to our attention was just 8%. The ferritin was 150, which is normal, and he had a mild anemia with a hemoglobin of 10 grams and a reticulocyte count that was quote-unquote in the normal range, but low for a patient with a hemoglobin that was outside the normal range. So this is actually a patient with iron deficiency. You might say, well, gee, the ferritin is normal. He can't have iron deficiency. But ferritin is an acute phase reactant. Any patient with an ongoing inflammatory process will have a normal or even elevated ferritin, even in the face of iron deficiency. And in this case, it's the patient who has other comorbidities that probably are contributing to that elevated ferritin. So we saw this as a patient with an iron deficiency anemia that needed to be treated prior to his elective surgical procedure. So is it anemia of chronic disease, iron deficiency anemia, iron deficiency and inflammation or immunosuppression? In this case, it's probably iron deficiency with a component of inflammation, as seen by a decreased transferrin saturation, but a normal ferritin. So these are the options, and I don't want to belabor this today because I want to make sure that we stay on time, but the recommended treatment for a patient with a combined iron deficiency anemia, anemia of chronic inflammation, is to consider intravenous iron and erythropoietin. And we're going to talk a little bit about whether to use erythropoietin in this patient with a prior history of colon cancer, given the concerns about erythropoietic stimulating agents and cancer recurrence, and recognize that we want to involve the patient in the clinical decision making about this. We don't have time to talk about this in any detail today. Suffice it to say that oral iron, not only is it poorly tolerated, but it is actually poorly absorbed and probably ineffective in patients with inflammation because of upregulation of a regulatory polypeptide called hepcidin, well described in the literature now. And the reality is that in a patient like this, even if he had continued to take his oral iron, probably would not have had an erythropoietic response to that oral iron. That is, his red cell mass and his hemoglobin would not have increased. So the obvious choice then is IV iron. So the standard regimen for our perioperative anemia management, we're going to go through these slides fairly quickly because we're going to talk a little bit more about this later in the day. We have to make sure that the patient is iron deplete before we use erythropoietic stimulating agents. Many patients will respond to IV iron alone, and in this case, there are some concerns about EPO because of the risk of thrombosis, which clearly is increased in patients being treated with EPO. Remember, this patient had an acute myocardial infarction 15 months prior to this surgical procedure that's being planned. So we have some concerns about thrombosis, and we have some concerns about the fact that he has a history of malignancy. So this was actually discussed with the patient, and we opted to treat him with IV iron alone. And if you go to the next slide. One of the things I want to emphasize is, and actually a number of years ago, there were some folks that went to the FDA and said, shouldn't we treat blood like pharmacologic agents, and if it's a risky therapy, shouldn't there be a black box warning? And the FDA basically said that's outside our mandate. We're not going to put a black box warning on every tag of every unit of blood that comes out of the blood bank. So I created my own black box warning. You're welcome to use this one, and that'll be provided with the slide. So I've mocked it up in a way that it mimics the black box warning that you see on pharmacologic agents. So we're going to treat this patient with intravenous iron alone because of the history of ACS and acute coronary syndrome and malignancy. Intravenous is the most common intervention that we use in preoperative anemia management. You can treat most patients in a single clinic visit with a gram of iron administered over no more than an hour's period of time, and expect to see in the patients with anemia of chronic inflammation, but also patients with iron deficiency anemia, a hemoglobin response anywhere between 1 and 3 grams per deciliter in that 3 to 4 week lead-up time that we typically look for in managing patients who are going to have an elective surgical procedure. So in our patient, we gave him 1,000 milligrams, actually 1,020 milligrams because of the way the drug is packaged of intravenous iron. We happened to use ferumoxytol in this patient, but I would submit to you that all of the irons that are available in the marketplace now are equivalent in terms of efficacy and risk profile, and really the decision is based on patient convenience in terms of how it's administered, the workflow through your anemia clinic, and the cost reimbursement equation that may be specific to your organization depending on other purchase organization type arrangements. On the day of admission, our patient's hemoglobin that started at 10 had now gone up to 12.8 grams per deciliter. He had an elevated reticulocyte count, which we are pleased about because we know he's going to lose blood during the surgical procedure, and his bone marrow is already primed to replace the red cells that he loses through the surgery. Patient signs informed consent for transfusion only if needed to prevent death from severe hemorrhage. He was very specific about that. So how do we try to ensure that this, what promises to be a fairly complex procedure, remember he's got a prior hip replacement that's loosened. This is going to be bloodier than the usual primary hip arthroplasty. How do we go about dealing with this? And keep in mind that this patient 15 months ago had acute coronary syndrome and has stents placed, drug-eluting stents has been placed on dual antiplatelet therapy. Clopidogrel is certainly an issue in terms of increasing blood loss. A patient who's on Plavix is going to bleed much more than someone who's not on Plavix. By the same token, what's the risk of thrombosing those drug-eluting stents if we discontinue this Plavix prior to surgery? The drug is not reversible. The inhibition lasts for the life of the platelet. And if you go to the next slide, we'll talk about the conversation and the considerations that went into managing this patient. These stents were placed 15 months ago. We know that the risk of stent thrombosis is greatest in the first year. There are, for patients who have to have a surgical procedure during that first year, and increasingly the recommendations are now looking at just 6 months of dual antiplatelet therapy. But suffice it to say that there are short-acting IV antiplatelet drugs such as Tarifaban that can be substituted for Plavix if you can't discontinue the Plavix. But in this case, we discontinued his Plavix 5 days before the surgery, and we placed him, he continued on aspirin. Warfarin, which remember he was being treated with warfarin for his atrial fibrillation, we discontinued that 3 days prior to surgery with a relatively modest risk, increased risk of thrombosis from his AFib during that very short period of time. Let's talk a little bit about anticoagulant reversal. In this case, we discontinued him 3 days prior to surgery. There are guidelines out there with regard to whether there's a need to bridge with another anticoagulant, such as heparin, which has a short half-life. We didn't feel it was necessary in the case of this patient. And keep in mind that this landscape is becoming much more complex with target-specific oral anticoagulants, and you see the advertisements for them on TV, rivaroxaban and other both anti-10A and anti-2 target-specific anticoagulants. Some of them now we're beginning to see specific reversal agents for these drugs, which the reversal agents themselves are very expensive. So this is complex, and it's part of the reason why for the elective surgical patient population, we want to bring them in and optimize them before surgery and deal with these issues in the 3 to 4 weeks leading up to surgery, rather than have the patient show up and Dr. Hannon and his anesthesiology colleagues now faced with a patient who hasn't been properly prepped, if you will, for their surgical procedure. What about tranexamic acid? You've heard a lot about antifibrinolytics. This is just one study that was published about 5 years ago now. In general, across a broad variety of surgical procedures, you see about a 1/3 reduction in blood loss if patients are treated with an antifibrinolytic agent. The greatest amount of data has been collected for tranexamic acid, but Amicar probably has a similar effect in terms of blood loss. And so I don't mean to promote TXA as opposed to Amicar, but the use of antifibrinolytics is certainly indicated in a patient like this, where he's essentially saying, I don't want to be transfused, do everything you can to minimize my blood loss. So the surgery takes place. We've done all these things in terms of using TXA. We've treated his preoperative anemia. It was a very complex surgical procedure. And on day one, our patient's hemoglobin is 6.7. His reticulocyte percentage is 7.8, so he's reticking like crazy. His iron saturation is better than it was when we first saw him, but still low at 13%. I like to target an iron saturation of 20% or more. And he's up and walking this first day after surgery, 15 feet with assistance, and he becomes short of breath and feels tired, which probably would describe many of us. So what would you do in response to that hemoglobin of 6.7 grams per deciliter? Nothing. Transfuse a unit of red cells, transfuse 2 units of red cells, begin oral iron or intravenous iron therapy. And what I hope that you are thinking right now is, well, number one, he's up and walking, he's hemodynamically stable. Of course he feels tired, he just had surgery the previous day. We're not going to transfuse him knowing the risks associated with red cell transfusion, knowing that he can respond nicely to intravenous iron, having increased his hemoglobin by 2.9 grams per deciliter in the 3 weeks leading up to surgery when we gave him his first dose of intravenous iron. The proper therapy for this patient at this juncture is to continue to give him intravenous iron. He has a significant iron deficit. He has to go from a hemoglobin of 6.7, hopefully back up to a normal hemoglobin of 13 or 14. That's about a gram of elemental iron to make that many red cells. And his iron saturation is only 13%, so he's got depleted iron stores as well. So we manage him with intravenous iron therapy. And in fact, one of the very interesting things you find as you begin to see patients with iron deficiency anemia in an anemia clinic is that a lot of their symptoms are associated with the iron deficiency itself and not the anemia. You give them an iron infusion and you talk to them 2 or 3 days later and they feel much better, even though their hemoglobin hasn't come up. And you might say, well, that's the placebo effect if they haven't gotten a bag of iron. But in fact, there's a good physiologic explanation as to why iron deficiency, independent of anemia, causes a lot of the symptoms that we associate with iron deficiency anemia. We can have that conversation later on this afternoon if there's time and you want. It's a very interesting part of the physiology of iron metabolism. In any event, we give them intravenous iron.
Do you switch them then to oral when they're discharged?
So when they're discharged, if they tolerate oral iron, we do supplement them with oral iron after discharge. Many of the patients don't tolerate oral iron, and the other thing to keep in mind is that post-surgical inflammatory response persists for a significant period of time. So a patient like this, we might bring them in post-discharge. So we develop a post-discharge plan for managing their anemia, and we might bring them in for additional intravenous iron 2, 3, 4 weeks after discharge from their surgery, depending on how they're responding, if they're tolerating oral iron, that sort of thing. When we prescribe oral iron, there are a couple of ferrous sulfate is the ferrous salts are the least well tolerated in terms of GI side effects. There are some other options out there that are better tolerated. Our particular preferred balance in terms of tolerability and cost are a variety. It comes in different brand names, but it's ferrous glycinate, which is an amino acid chelate with iron, and has been shown to be better tolerated. The other thing that we've learned, some very interesting data that's really just, I think, 2 or 3 years old now, is that every other day dosing is probably more effective than daily dosing in terms of absorption. It has to do with the hepcidin pathway and the upregulation of hepcidin, which when you give oral iron, hepcidin levels upregulated. So by giving it every other day, you keep hepcidin relatively lower, so you get better absorption from the oral iron.
So I just wanted to make one point here. So in this guy who's very attuned to transfusions, he's basically said, don't transfuse me unless I'm exsanguinating. So you have an ongoing informed consent discussion with this patient. Going for intravenous iron is very reasonable. I just want to point out that the McLaren transfusion guidelines are 7. So if a hospitalist or an orthopedic surgeon gave a single unit of blood to this patient or a similar patient, that would not be outside of the guidelines. Right. So again, this is a very aggressive situation with a fully informed patient. I just want to make people understand we're not advocating transfusing everybody at 6.7. And I would also say, because we will talk a bit about OB hemorrhage, I've had the conversation with many young 22-year-old brand new moms that have hemoglobins of 6-ish and said we can either transfuse you or give you IV iron. And in that case, the patient was informed about the decision. But again, in this guy, I don't think anyone would be faulted for transfusion of cells.
No, absolutely not.
And I would just, not to belabor it, but I would just, one of the things that kind of bothers me about informed consent for transfusions, it's signed, it's not typically discussed, and it's executed. To me, this is the patient is awake, informed, knows what's going on. Why wouldn't you go to the bedside and say, here's our options, you're doing pretty well, we can certainly give you IV iron, there's no harm, there is an argument to transfuse you, what would you prefer to do? What I see in more practice, again, if the patient's asleep under anesthesia, it's okay, but most transfusions are not to patients under sleep anesthesia. They are patients who are fully awake, cognizant, and if properly informed. It really should be the physician goes to the bedside, talks to the patient and their family about this is what we can do, here's plan A, plan B, plan C. It rarely happens. But again, I think that's the way to do it, and that's what I described for plenty of OB hemorrhage patients. It would bottom out somewhere between 5 and 6.5. Is I'd ask them what they wanted to do and let them make the decision. And then I would document that I made that decision with them, as opposed to I'm just always going to transfuse or never going to transfuse.
And it's exactly we're exactly on the same page.
Do you discuss this with your patients at your pre-op visit?
Yeah, all of this, back, so I'm not currently at my hospital. This was a few years ago, but that was exactly what we did. When we had patients come to the anemia clinic, it was actually, a part of we worked hand in glove with the anesthesia service in terms of pre-op optimization. And we had all these conversations. And what we then tried to do was develop a comprehensive plan, pre-op, intra-op, and post-op planning. We shared that with the surgeon, with the anesthesia service, because we didn't know who the anesthesia provider was going to be on that particular day, and with the primary care doc, so that everybody was on the same page. It was fully integrated. The orthopedic surgeons love this. They actually, the way we structured our program is if they scheduled a surgery that was on a list of surgeries that were potentially high blood loss surgeries, the patient was automatically enrolled in preoperative anemia assessment and management. And so they didn't have to write an order for anemia management. They didn't have to worry about it. They knew that on the day of surgery, if they hadn't heard from us, their patient would have normal hemoglobin. If they had heard from us, the patient was going to be optimized to the extent possible. Or on rare occasion, we told them, if this is truly an elective surgical procedure, we need to put it off because there are other issues going on. A patient with an unexplained severe iron deficiency, it's a 68-year-old male, well, geez, he got GI blood loss, that needs to be evaluated before we consider doing an elective hip replacement or elective knee replacement, that sort of thing.
So I'm going to assume you probably saw a lot of geriatric patients.
Yeah, when our anemia clinic started, it started with just hip and knee replacements, and almost all of those patients were 60 years and older. And interestingly enough, we saw a lot of bariatric, post-bariatric surgery patients in that patient population, especially for knee replacements, because they'd been morbidly obese for a long period of time. And that was actually how we dipped our toe into non-surgical anemia management, because these post-bariatric surgery patients, 3/4 of them were iron deficient because of the surgery that they'd had, and we recognized that there was a need for ongoing anemia management in the community, a need that wasn't being met by the existing services. So that's something, it's a very broad ranging discussion that one can have about a health system and how they approach anemia in the community from a population and community health perspective. And that's a particular area of interest of mine, because anemia is surprisingly common in your patient population.
Yeah, I don't think it's on our agenda today, but us understanding the granular decisions and operability that needs to be put in place to have an anemia clinic. I don't think we have that within the McLaren subsidiaries. I could be wrong, but I think understanding what the steps are involved.
Yeah.
So we do have it as a placeholder conversation, and likely, if there's not one, excuse me, you go where the money's at. So in orthopedic surgery, they're going to lose a lot of blood. They're elderly. 40 to 50% of elderly patients are anemic, so that seems to be a good starting point. But as Dr. Gross was saying, there's a lot of other patient populations at risk that could be treated with this. But again, let's kind of wrap up this conversation, and we'll talk about that in kind of at the end of this.
So Tim, in the interest of time, and I haven't bothered to look at my watch, and as usual, I'm sure I'm way over. I can end here, or we can, I'm perfectly happy to do so.
We're up on time. Maybe so the guy did great. You won a Nobel laureate for this. I mean, kind of tell us the end of the story.
So he went home, I think it was post-op day 3, which was about average for hip replacement patients. We had him come back to the anemia clinic for additional intravenous iron. And 8 weeks later, he had a hemoglobin that was near normal, and he was doing great, and was very happy with the outcome. So these patients, and this was a very complex hip replacement and revision. So you can manage these patients. If you manage them aggressively, you can avoid transfusion in patients like this. But it requires absolutely a coordinated, integrated, and team effort in order to get there. Any one of the things, had we not done them, he almost certainly would have ended up being transfused, which was not what he wanted. And I think that that's central to the conversation is patient choice and patient autonomy as well.